Prof examination. And I will also tell you which are the short notes, enumerations, and the MCQs topic, and also the long question and viva question. So before that, I just want to know is everything is fine and I'm audible so that we can start the session. Let me just check. Okay. So yes, everything is fine. I'm audible. Do let me know so that I can start the session. So I think everything is fine. Okay. Yes. Okay. All fine. So very good. Let's start with the session now. So actually, the questions which is asked from this topic is more, so already all types of joints and type we have discussed in the general anatomy session. जब मैंने joints के sessions लिए थे general anatomy series में, तो मैंने सारे types of joint along with the example I have already told you. Now, in upper limb, the most important joint which is asked for your long question is the shoulder joint. So the best part is that you should also know what we exactly mean by the word shoulder joint complex. So when I am using the word shoulder joint complex, it's important for us to know that it is actually formed from following joints. So basically, if I'm talking about shoulder joint complex, it is formed from the glenohumeral joint, that is the shoulder joint. It is also formed by the acromioclavicular joint. Okay, you can see this is the acromial process of the scapula, and this is the clavicle. So acromioclavicular joint, and also we have got the sternoclavicular joint. Okay, so that all joint along with the scapulothoracic articulations which will work, which is a functional linkage, and this will work together to function as a shoulder joint complex. Okay, so here we can see the glenoid cavity which is articulating with the head of humerus, the shoulder joint. We can see the acromioclavicular joint, and also we can see that this is the clavicle having its medial end which will articulate with the sternum. So that will form the sternoclavicular joint. So, and the scapulothoracic linkage, which is a functional linkage, which is also the part of shoulder joint complex. Now, before exactly starting with the session, I want everybody to know that important questions, which is very important to be asked for your viva and your theory examination, university first prof examination. Either a long question can come on shoulder joint, where you have to know where, if I'm talking about this long question, you have to know about the ligaments, you have to know about the relations, you have to know about the important you have to know about your important ligaments, movements which is taking place at the shoulder joint, and you have to also know about clinical anatomy. Actually, one of the movement, that is abduction of shoulder joint, can come as a separate short notes, and you have to know about the tendon which is intracapsular in relation to shoulder joint. You have to know about the ligaments, you have to know about the stability of shoulder joint, how it is increased. You have to know the movements, which is lateral rotators of the shoulder joint, medial rotators, flexion, extension, abduction, adduction. So all these things will be asked in examination. Now, as I have already told you, whenever I talk about the basic point, that is the shoulder joint complex, it is not just including shoulder joint, but includes, so let me slightly enlarge this image. Okay, so if I'm talking about shoulder joint complex, it includes following important joints. So please pay attention to this image. Okay, so what all things are included here? So it is including acromioclavicular joint, it is including sternoclavicular joint, glenohumeral joint, and the scapulothoracic joint, which is a functional articulation. So basically these four joint together function. So basically when I will explain the movements of joint, I will explain abduction of shoulder joint, which is a very important movement, and I will also explain how these all four joints are involved and why we take these joints as together as the shoulder joint complex. So basically this is an important question of viva, where they can ask you which all joints are included in shoulder joint complex. So I have already marked these four joints are included in, these four basic articulations are included in the category of shoulder joint complex. Okay, now coming to the next, let's talk about the shoulder joint. So basically starting with the topic of shoulder joint, I want everybody to understand that what all things will be completed or by the end of this session. So when I am coming to the end of this session, okay, Yeah, good evening, Mudit, everyone. Good evening. So when I will come to the end of this session, I want that you should be able to know all these important correlations with the shoulder joint. So what will be the key features and what will be the learning objective of this session? So we should be knowing about articular surfaces, the type of joint, the ligaments. So I will explain the primary ligament and accessory ligament in relation to shoulder joint, the bursas related to the shoulder joint, relations of shoulder joint, the arterial and the nerve supply, the factors which increases the stability of shoulder joint, movements of shoulder joint, and the clinical anatomy. Yeah, good evening, everyone. So, before exactly showing you writing about the type, I just want everybody to focus on this image. Why? Because if you will see this image, you will have a better idea of articulating surfaces. Okay, so this is important for you to understand which are, so basically if I talk about shoulder joint, glenohumeral joint, everybody is knowing that it's a ball and socket type of synovial joint. Okay, now it is an articulation which is taking place between the glenoid cavity. So in this diagram you can appreciate the glenoid cavity. Okay, so this is the glenoid cavity which I have highlighted. So the glenoid cavity which is shallow, can you see this glenoid cavity is shallow as compared to the acetabular cavity which is seen in the lower limb and which forms hip joint. So this is shallow and this has to articulate with the head of humerus. So I would also like to show you another image where you can see head of humerus. So what you can appreciate here, the head of humerus is not a complete spherical. Okay, it's not a complete spherical, and the glenoid fossa is shallow in comparison to head of humerus. So basically this is the reason it is the most common joint to get dislocated, and it can undergo recurrent dislocation. Therefore, it's very important for the students to read shoulder joint in details. Okay, the shoulder joint, which is a ball and socket type of synovial joint, it's a polyaxial, multi-axial joint which is having great degree of mobility. So it's a highly mobile joint, but in the other case, it is not a very stable joint. Recurrent dislocations are quite common in case of shoulder joint. So we will see how the shoulder joint stability is increased by many of the factors and what are the ligaments which is supporting it. Okay, so that is very, very important. If I talk about the glenoid cavity, so can you see this glenoid cavity in this image? So if I'm talking about the glenoid cavity is deepened. Okay, it is deepened effectively by fibrocartilaginous ring which is called as glenoid labrum. So glenoid labrum will increase the hollowness of, or will accumulate the head of humerus perfectly and will increase the stability of shoulder joint. So these are few of the key features which everybody should know. So please write on this. Okay. So we have to know about articular surface and type of joint. So basically if I talk about type of joint, it is ball and socket type of synovial joint. Okay, dear students, it's a ball and socket type of synovial joint, and it is having an articulation. So shoulder joint is having an articulation between the large round head and glenoid fossa. So basically the articulating parts are, this is the glenoid cavity. So we have got a shallow glenoid cavity which is articulating. And one more key point you have to write, that there is a fibrocartilaginous rim. So the glenoid cavity is deepened. If I talk about the glenoid cavity, it is deepened by fibrocartilaginous ring which is attached to the margins of the acetabular margin of this glenoid cavity margins to deepen the glenoid fossa, called as glenoid labrum. Okay, now let's see the other articulating part. The other articulating part which can be seen in this image is the head of humerus. So the other articulating part is the head of humerus. So the articulation is taking place between the rounded head of the humerus with a relatively shallow glenoid cavity. And the type of joint is ball and socket type of synovial joint. So before proceeding to the next, it is important that we should appreciate this joint in this image. So I would like to show you a radiological image here. Okay, so in this radiological image, you can see the glenoid fossa and the head of humerus. So here we can see this is the acromial end of the, we can see here acromial end of the clavicle. We can see here the humeral head, which will articulate here with the glenoid cavity, the shallow-glenoid cavity. And this is exactly the glenohumeral joint space. So this is actually an AP view, anteroposterior radiological image showing the shoulder joint. Now moving up with the next important, a very important topic about shoulder joint, which is definitely asked in the examination, either in the university paper or in the viva practical exam, is the important ligaments which is supporting the shoulder joints. So ligaments of shoulder joint is the next topic to be known. So I just want everybody to write important points here, which are, so firstly, I would like everybody to note down the primary ligaments. Okay. So firstly, write down the name of primary ligaments. So the important primary ligaments, which I will explain first, is the fibrous capsule of shoulder joint, the glenohumeral joint, the also the coracohumeral joint, and we will have the transverse humeral ligament. Actually, there is also another ligament that is called as coracoacromial ligament. Actually, coracoacromial ligament, along with the acromial and coracoid process of the scapula, is called as the coracoacromial arch. So that is giving accessory support or secondary support to the shoulder joint. So important primary ligament of shoulder joint is the fibrous capsule, capsular ligament, which is lined on inner aspect by the synovial membrane, forming the joint capsule, which is a key feature for all kind of synovial joints. We have got the glenohumeral ligament, we will have the coracohumeral ligament, we will have transverse humeral ligament, okay. So these are 4 primary ligaments which is supporting the shoulder joint, and other than that, please write down the accessory ligament or support. So these are primary ligament, and I would also like everybody to write down the name of accessory ligament or support, which is given by coracoacromial ligament along with coracoacromial arch. Okay. So actually, whenever I take a topic, we are going to complete the entire topic, means covering all the viva questions, practical questions, and the theory paper. So either a short note can come from this session or a long question can come in the university exam. Now, next, let's see a image, and this is an image which is a coronal section. So what you can see, this is the coronal section of the shoulder joint, in which you can appreciate the fibrous capsule. You can see the glenoid labrum also. So I'm just slightly enlarging this image. So when I slightly enlarge this image, you can clearly visualize here. So here we can see the capsular ligament. So this is the capsular ligament which is shown, fibrous capsule, and also we can appreciate that it is lined on inner aspect by the synovial membrane. Okay. Also superiorly we can appreciate here, on the superior aspect we can appreciate the acromial process is here. This is the acromial process. We can also appreciate in this diagram the glenoid labrum, the glenoid labrums. Okay, these are the glenoid labrums. Okay, and in this section we can also see the glenoid cavity. Okay, and we can also see the fibrous capsule. If I'm talking about the file, let me just use another color so that you can appreciate here. So we can see the fibrous capsule here, and this is the fibrous capsule. Okay, this is exactly the fibrous capsule, which is Actually, on the lower aspect, it is descending slightly lower down. So only inferior dislocations are common in the shoulder joint. Okay. So we can see the axillary recesses here, and we can see the surrounding muscles. So superiorly, we have got the muscles fibers, which you can see the supraspinatus tendon muscle, which is lying here. So you can see superiorly, we will have the supraspinatus muscle below the coracoacromial arch, and overall almost superior to this muscle, we have got the shoulder joint covered here by the deltoid muscle. So this is the coronal section which is shown to you, and I will also make a coronal section line diagram so that you can make that diagram in your university examination. So let's talk firstly about the fibrous capsule of the shoulder joint. So basically, if I talk about the joint capsule of the shoulder joint, it is actually attached to the margins of glenoid cavity. So it is attached to the margins of glenoid cavity beyond glenoid labrum. Can you see here? So obviously I have shown you the glenoid labrum. So this is the glenoid labrum. So beyond the glenoid labrum, we have got the attachment of fibrous capsule. And what is the function of this glenoid labrum? Fibrocartilaginous ring. This is deepening the or making the shallow glenoid fossa slightly more deeper so that it will increase the stability of shoulder joint. Okay. So let's talk firstly about the fibrous capsule. So attached medially to the margins of the glenoid cavity beyond glenoid labrum, and it is attached onto the humerus bone, that is the anatomical neck. So basically, except inferiorly. So when you see the inferior aspect, can you see here, this area is called axillary recesses. Why? Because fibrous capsule attachment on the inferior aspect is descending down, not exactly onto the anatomical neck of the humerus, but it is descending slightly down, approximately 1.5 centimeter more onto the towards the surgical neck of the humerus bone. Okay, so only inferior dislocations are common in the shoulder joint. So that is very important. And another one important point is that if I talk about the attachment of fibrous capsule, it is attached beyond the supraglenoid tubercle, and supraglenoid tubercle is giving attachment to the long head of biceps brachii. So only long head of biceps brachii is located within the joint cavity. This is a very important point. So these are the key points which everybody should know. So please write down about the joint capsule or the capsular ligament. So what is joint capsule? It is the thin fibrous layer which is surrounding the glenohumeral joint. So important point is, it is a fibrous layer surrounding glenohumeral joint. Okay, now coming to its important points and attachment. So it is important, and in the viva examination also many times your examiner will ask about the fibrous capsule attachment. So attachments, let's talk about attachments. Attachment. So it is attached medially. Fibrous capsule is attached medially to the margin of glenoid cavity. Okay, beyond the glenoid labrum, and laterally to anatomical neck of humerus bone. Okay, dear. So that means medially towards the margin of glenoid cavity, laterally to anatomical neck of humerus bone. Okay. But if we talk about downward descent, so inferiorly and inferiorly, the attachment of fibrous capsule descends 1.5 centimeter down onto surgical neck of humerus. Okay, that is an important point which everybody should know. Okay. And one more important point about the medial attachment is that it encloses the long head of biceps brachii. So it also encloses, so medially, if we talk about the attachment, is beyond supraglenoid tubercle, and that is including the long head of biceps brachii. Okay, so it's also important medially. Medially, the FC for fibrous capsule extends beyond the supraglenoid tubercle and it encloses what? It encloses long head of biceps brachii. Okay, my dear students, so this is a very important point which everybody should know. And so many times the MCQ has been asked, or in the viva also this question has been asked, that which of the following muscle or tendons are intracapsular, lying inside the synovial. And the answer is, it's the long head of biceps brachii. Okay, now let's talk about the synovial membrane. The synovial membrane lines the inner aspect of the joint capsule, and it is reflected from it to the glenoid labrum and humerus as far as the margins of the head. So if I talk about the synovial joint of the glenohumeral joint, it forms a tubular sheath. It is forming a sheath around the tendon of long head of biceps brachii, which is passing through the bicipital groove. I think in the previous session, I have already shown you the bicipital groove, which is lying between the greater and the lesser tubercle of the humerus bone. And it communicates with the, if I talk about the communication of the joint cavity, it communicates with the infraspinatus and subscapular bursas. Okay, so let's write this few important points. Okay. Synovial cavity of joint has got two important features. So its two important features, it forms tubular sheath around the tendon of biceps brachii. Okay, biceps brachii when it is present in the, when it is tendon is passing through bicipital groove. Okay, that is important. The other point is, it communicates with two bursas. It communicates with subscapular and infraspinatus bursa. Okay, so when I will discuss the bursas around the shoulder joint, I will discuss the location of all important bursas around the shoulder joint. Now, this is an important point about the joint capsule. So now, if I want to just summarize the joint capsule having inner aspect, the synovial membrane. So important point about the joint capsules or the joint cavity of shoulder joint is that it is having an opening which is located between the greater and the lesser tubercle for the passage of long head of biceps brachii in between the greater and the lesser tubercle of humerus bone, and also an opening is situated anteriorly inferior to the coracoid process, which is allowing the communication of the joint, synovial joint cavity with that of subscapular bursa. And if I talk about the posterior aspect, posteriorly the synovial joint cavity of the glenohumeral joint is communicating with infraspinatus bursa. That means these are the three important points. So basically, we'll make a diagram also, the coronal section which I have shown you. But before that, please just write on three apertures. There are three apertures. There are three apertures which is present in the joint capsule of shoulder joint. Okay, so three apertures present in the joint capsule of the shoulder joint is, so first aperture is an opening between tubercles of humerus bone. So for what? For the passage. So this is for tubercle of humerus bone for the passage of long head of biceps brachii. Okay, so many times we have discussed this, and I will show you an image also regarding this. And we will have two apertures. One aperture is lying on the anterior aspect and the one aperture is lying on the posterior aspect. So an opening situated anteriorly which lies on the inferior aspect of the coracoid process, forms anteriorly, communicates between synovial cavity and subscapular bursa. And the other communication is located posteriorly. The third important, so an opening situated posteriorly. To allow communication between the synovial cavity and that of infraspinatus bursa. Okay, so these are the three openings or apertures which you have to know. These are the three important openings or apertures which you have to definitely know about the joint capsule of shoulder joint. So till now, any doubt, please, my dear students, if you have got any doubt. Okay, dear, yes. Good evening. Yeah, good evening, everyone. If you have got any doubt, please let me know. Okay. Okay. So basically, in between, I'm checking your messages. So now we have completed the fibrous capsule and we are knowing the attachment of the fibrous capsule both medial and laterally. And the key points which we have achieved till now is that on the inferior aspect, the fibrous capsule is descending to the surgical neck of humerus. And so the shoulder joint is more not it's a loose inferior aspect. So there is chance of dislocation of the shoulder joint. Other important point is the three apertures which I have discussed and the attachment of fibrous capsule. Now, next, yeah, I have already shown you the coronal section. If you will see, I have already shown you the coronal section in which we have seen the synovial, cavity, and we have also seen the capsular ligament and synovial membrane. Now, I just want everybody that please make a simple line diagram for the coronal section in which you can appreciate the superior aspect. There is coracoacromial arch, and you can also appreciate the fibrous capsule and the glenoid labrum attachment. So, and also so I will make a simple diagram to help you to understand that. Okay, so let's make a diagram. And before that, I just want you to show this image. Actually, in this image, you can see the synovial membrane lining the interior of the shoulder joint and its extension. So you can see the synovial membrane of glenohumeral joint. You can see it is extending and anteriorly communicating with the subcapsular bursa. Is it clear? You can also see that it is forming a sheath around long head of biceps brachii. So here you can see this is the tendon of long head of biceps brachii. And around it, I will use blue color for the synovial membrane and sheath. So you can see this is exactly extending. So actually it is from the anterior aspect. So you can see the communication with the subscapular bursa. And you can see that this synovial membrane and sheath is covering the tendon of long head of biceps brachii, which will be actually here you can appreciate there is a ligament that is called as transverse humeral ligament. And actually this transverse humeral ligament is connecting greater and the lesser tubercle of the humerus bone, and beneath it passes the long head of biceps brachii. Okay. Also on the superior aspect, you can see the acromial process, you can see the clavicle, and you can see the acromioclavicular joint. Okay, you can also see the coracoacromial ligament, which is connecting the acromial and coracoid process. So this is the acromial and coracoid process, which is connected by the coracoacromial ligament. So it is important for us to make a coronal section now. Okay. So now let's make a coronal section, and I will firstly write the heading. So let's make a diagram. Coronal coronal section through shoulder joint. Okay, so we are making a coronal section through shoulder joint, and I want you to show the important structures surrounding. Okay, so let's make a diagram. So we can have an outline. What I have made here is shallow glenoid cavity and head of humerus. Okay, head of humerus. Now the synovial cavity. Okay. So we can use a different color for the synovial cavity. Okay, always use colors in the anatomy diagram for getting a better mark. So you should use you should make diagrams using different colors. Okay, and on the margins of the articular margins, we can also draw the glenoid labrum. So let's draw the glenoid labrum. I will use green color for the glenoid labrum. Okay. Superiorly, we can, if it is a coronal section, so superiorly we can make the coracoid process, the acromial process, and the connecting ligament of coracoid and acromial process, that is called as coracoacromial ligament. Together, they are called as coracoacromial arch. So let's make acromial process. Coracoid process and connecting structures, coracoacromial ligament. Okay, so here we will have, and all here I will also make a muscle here. This is a supraspinatus muscle which is lying here. Okay. Okay. Okay, so let's label it. So this is coracoid process. Can anybody tell me coracoid process is which type of epiphysis which I have completed in the previous session? This is coracoid process, my dear students. And this is the acromial process. Got it? And the structure which is connecting it is coracoacromial ligament. Okay, so these three structures together, so if we connect these three structures together, that is the acromial process, the coracoid process, the coracoacromial ligament, this is called as, I can use a different color to, this together is called as coracoacromial arch. Okay. So we have seen the important structure which is supporting the shoulder joint from the superior aspect. Now, other than that, and also we know that onto the acromial process, we have got the attachment of acromial fibers of the deltoid muscle. So you can just draw here with brown color only. You can draw the we can sew the deltoid muscle. These are the fibers of deltoid muscle. Okay. Okay. So we can just label it. And below this means in between the deltoid muscle and that of the shoulder joint, beneath it we have got the subacromial. Below the acromial process we have got the subacromial bursa. So I will use a dotted line to just represent this. Okay, so I will use a different color, maybe, yeah. So we can use this color to show you the subacromial bursa. Actually this is the deltoid muscle. So this is the supraspinatus muscle. This is the deltoid muscle. This is deltoid muscle. This is supraspinatus muscle tendon. And this is the subacromial bursa. Actually, subacromial bursa is also termed as subdeltoid bursa because it is located between the deltoid muscle and the shoulder joint. So now it's important to sew the fibrous capsule attachment, which was very, very important for us. Okay. So for fibrous capsule attachment, again, I am going to use green color. Okay. So articular margins, it is attached to the articular margins beyond the glenoid labrum. This is, and here it will be the towards surgical neck of humerus. So it is descending towards the surgical neck of humerus. So this is exactly the fibrous capsule. So let us got it? This is exactly the attachment of fibrous capsule which I have demarcated here. Okay. So this is fibrous capsule or capsule of shoulder joint. So what you can see that it is descending lower down. It is descending. So here we can see what is this? This is glenoid. These are glenoid labrum. This is glenoid attachment of glenoid labrum. This is again FC for fibrous capsule. This is again glenoid labrum and this is the fibrous capsule. Okay. So here close to that of the if I talk about this close to the surgical neck of humerus, we know we will have the location of axillary nerve and posterior circumflex humeral vessels, which we have covered in the previous session. So I will use yellow color for the nerve and I will use red color for the arteries. Okay. So please mark it. So two structures are related. One is the axillary nerve and the other is posterior circumflex humeral vessels. Okay. So got it. So here we are now knowing, and this is the glenoid cavity of scapula. This structure is glenoid cavity of scapula. Okay, so now we have made this coronal section in which we can see many of the important structure, the glenoid labrum. We can see the relation of axillary nerve and posterior circumflex humeral vessel. We can also appreciate the fibrous capsule attachment is descending from anatomical neck towards the surgical neck of humerus, lying close to the axillary nerve and posterior circumflex humeral vessels. We can also see the subacromial bursas. We can also see the glenoid cavities. We can also see the fibrous capsule attachment and the parts of coracoacromial arch, the coracoid, the acromial process and coracoacromial ligament, which is supporting the shoulder joint superiorly. Okay. Okay, so done with this. Now Now let's talk about the ligaments. Okay, so I will just, I have also shown you the synovial membrane in this diagram. Is it okay? So we have also talked about the synovial membrane in this diagram. And after that, so it's also important. So it's also important if we can also have a diagram where we can also demonstrate the synovial membrane, which is showing its extension. So we have seen the synovial membrane is having, it's lining the inner aspect of the fibrous capsule, having the, it encloses the, it is extending towards the anteriorly to subscapular bursas, and it is also forming a sheath around long head of biceps brachii. So we can make a simple diagram for showing the extensions of synovial membrane lining the interior of the shoulder joint. So again, I will make a simple diagram. This beak-like process is what? This beak-like process is the coracoid process. Okay, so acromial process, what I have made this as the acromial process. This will be the acromial process of scapula. This is the coracoid process of scapula. And the structure which is connecting coracoid and acromial process is called as the ligament. Which ligament? It is called as coracoacromial ligament. So I will use green color for the ligament. Coracoacromial ligament. Got it, dear? Okay. Now, thereafter, also we can draw the outline of the humerus bone, but here we will draw again a transverse humeral ligament. So this is exactly okay. So I will use for synovial membrane, I want to use this violet color. This is whole of the synovial membrane cavity extension. Is it okay? Yeah. So this is exactly what I have made is the synovial membrane. Lining the inner aspect of the fibrous capsule, having communication with the, what is this? This is subscapular bursa. Okay, bursas are around the muscles and joint to have a smooth coordinated movement and lubrication. Okay, so and lower down this will be this is outline for the humerus bone only. Okay, and here I want you to show a tendon. This again I will use a green color for this tendon sheath. This is long head of biceps brachii, and this is the ligament which is covering the greater and lesser tubercle, and this will be the extension again the synovial sheath. So this will be the synovial sheath. This is the synovial sheath around tendon of biceps brachii, and this is the tendon of biceps brachii. Okay, so and this ligament which is connecting the greater and the lesser tubercle of humerus bone, what is it called as? Transverse humeral ligament. This is transverse humeral ligament. So is it okay? So now in this diagram, so bony processes, you can either, if you have got time, you can use gray color so that it gets better. That these are the bony prominences, acromial process. the cut part for the bone. Is it okay? So this is a diagram showing the synovial membrane extension anteriorly forming communication with subscapular bursa, as it is from the anterior view. So you can't appreciate the communication with the infraspinatus bursa. You can also see the synovial sheath formed around the tendon of biceps brachii. Is it okay? So after this, let's talk about other ligaments supporting the shoulder joint. Till now, is it any doubt to my dear students? Okay. Okay. No, my dear students, it's not very difficult. It's an easy part only. Only the thing is that you have to understand. And I always tell you, because I am drawing each and every diagram and I'm writing the notes along with you, so that we can clearly, we can complete the whole thorough preparation for all university question papers, questions, and the viva questions. Okay, so we have finished with the fibrous capsule, synovial membrane, joint cavity, extension, and the next is to describe the important ligaments of shoulder. So I would like to start with glenohumeral ligament. Okay, so I have already given you the names of important ligaments. Now let's see this. So before that, let me show you a few of the ligaments. Okay, many of the ligaments we have drawn also. So a few ligaments which is exactly shown in this image. So here we can appreciate coracoacromial ligament, and we have drawn this also. Here we can see the connection is between the coracoid process and that of, so we can see the connection is following. This is connecting. So what will be the attachment? The attachment is from the coracoid process and the acromial process also. So this part of the ligament is coracoacromial ligament. Also we can see here the coracohumeral ligament. We can see the transverse humeral ligament. And we can see the fibrous capsule of the joint, and this is the axillary pouch. So basically, and we can also see the biceps tendon here. Now, my dear students, other than that, adjoining ligament, coracoclavicular, coracoacromial ligament has been also shown, this the neighboring structures. Now, exactly if I talk about the fibrous capsule, the glenohumeral ligament is actually the thickening of the fibrous capsule of the shoulder joint. Okay, we have got three glenohumeral ligament. We have got superior, middle, and inferior glenohumeral ligament, and it is very important for increasing the stability of the shoulder joint. It is the primary support for the shoulder joint, as it is a thickening of the shoulder joint, which is actually giving, it is acting as a static stabilizer connecting the humerus and that of the glenoid fossa. So let's write one by one. So I will just want to describe the first category of ligament. So we have already finished the fibrous capsule. Let's talk about the glenohumeral ligament. Okay, glenohumeral ligament is actually three in number. We have got superior glenohumeral ligament, we have got middle, and we have got inferior. So we have got three glenohumeral ligaments, superior, middle, and inferior, which is increasing the stability of shoulder joint. So these three glenohumeral ligament act as a three fibrous thickening of shoulder joint. It is actually fibrous thickening of shoulder joint capsule. And it acts as a static stabilizer of shoulder joint and increasing the stability of shoulder joint, which connects the humerus to that of glenoid cavity. So it is actually increasing the stabilization between the head of humerus and that of the glenoid fossa. So that is very, very important. Actually, especially if I talk about they are very important for limiting excessive dislocation of shoulder joint, especially in the inferior and anterior. So if I talk about this three glenohumeral ligament, which is actually the thickening of fibrous capsule of shoulder joint, its function and it is why very crucial. The reason is that it is limiting excessive movement of shoulder joint. Okay, especially which movement of shoulder joint? The inferior and and that of anterior. So antero-inferior dislocation, basically it is limiting antero-inferior dislocation. And what is its function? This will increase or provide stability. So it is increasing the stability of shoulder joint. Okay. And one more important point about glenohumeral ligament is that it will be more clearly visible once you once you see the interior of the joint. So it becomes more of clear. So let's see that. So this is also external view. This is also external view. I would like, okay. So see here, this is an image where you can appreciate the inferior view, interior view. So we can see the interior view here, and in the interior view, okay, in the interior view, you can appreciate the glenoid fossa. This is the glenoid fossa, which you can see. This is the glenoid fossa, surrounded by glenoid labrum. Okay. And also we will have the glenoid labrum, and we will also have the merging. Actually, there is three glenohumeral ligaments. So we can see there is inferior glenohumeral ligament, there is middle glenohumeral ligament, and there is also the superior glenohumeral ligament. So very nicely you can see these three glenohumeral ligaments. Let me highlight this. This is the superior glenohumeral ligament, this is the middle, and this is the inferior, which is also forming the axillary pouch, and these will merge with this is increasing the stability, and these will merge with the fibrous capsule of the shoulder joint and surrounding. So exactly they are increasing the stability of shoulder joint. So the visibility of these three parts of glenohumeral ligament is more visible once you open up the joint. So you can see the interior of the joint. Okay, so that is shown to you. Okay, now I would also like to tell you about other ligaments. So let's, we have finished the two important ligaments already. As you can see, we have finished about the fibrous capsule. This was the second one. The first is the fibrous capsule. This was the fibrous capsular ligament. So we have finished the fibrous capsule. We have talked about it in detail. We have also finished about the glenohumeral ligament, and let's talk about the third ligament, which is giving primary support to the shoulder joint. This third ligament is, so let's talk about the third ligament. Okay, coracohumeral ligament. Coracohumeral ligament. So actually, if you're knowing the name, you can give me, you can understand the attachment also. If you are knowing the name, you can tell me the attachments also. Okay, so when I'm talking about coracohumeral ligament, it means it's a strong fibrous sheath which is actually connecting the base of coracoid process to that of anterior aspect of greater tubercle of humerus. So this is attachment. This is an important point about attachment of coracohumeral ligament. The word coracohumeral. So it is connecting coracoid process of the scapula and that of the greater tubercle of humerus bone. So it's a strong ligament connecting base of coracoid process and anterior aspect of greater tubercle of humerus. Done? Okay. Now, talking about the fourth ligament, which we have also seen, that is transverse humeral ligament. So the fourth ligament which you should know is the transverse humeral ligament. So let's talk about transverse humeral ligament. The transverse humeral ligament is connecting the greater and the lesser tubercle of the humerus bone. So basically, it's a broad fibrous band which is connecting, which is actually, it is covering, or you can see it is bridges. It bridges the bicipital groove. So it is bridging the bicipital groove, means it is connecting the greater and the lesser tubercle of the humerus bone. So it is actually located between, it is connecting the greater and the lesser tubercle of humerus. Okay, and it so below, exactly why it is important, the ligament is actually converting this groove into a canal. So if I talk about bicipital groove, it is converted into a canal by the passage of long head of biceps brachii, and transverse humeral ligament is covering this. It is actually bridging the bicipital groove, connecting the greater and the lesser tubercle. So basically, it provide a passage for the long head. So an important point for MCQ is that it is providing passage. It provides passage for the for the long head of biceps brachii, for the long head of biceps brachii, which is covered by a synovial sheath, and this is covered by a synovial sheath, which we have already seen in the diagram. Okay. So done with this. Now again, I will once more, I will show you one more. We will talk about bursas before that. So let's, okay. So we can, we have seen the ligaments. We have seen the coracohumeral ligament here. And we are knowing that coracohumeral ligament is an important ligament which is supporting the joint. It is connecting. So if I talk about coracohumeral ligament, it is connecting the coracoid process and the greater tubercle. We have also seen the glenohumeral ligament. We have also seen the transverse humeral ligament. Okay, so we have seen various ligaments. So here we have seen the transverse humeral ligament. Here we can also see superiorly, this is accessory ligament of support, that is coracoacromial ligament. Okay, and this structure is the GT, the greater tubercle of the humerus, which is connected to the coracoid process, that is coracohumeral ligament. Okay, this is coracohumeral ligament. So we have appreciated this in this image, but we should draw line diagram to show this. Okay, so I want everybody to draw few of the diagrams along with me to show the important, so to know about the important ligaments. So let's make a, so actually I will show you a line diagram showing the interior of shoulder joint, in which we can see the three parts of glenohumeral ligament. I will also draw another ligament which will showing you the coracohumeral, acromial and transverse humeral ligament. Okay, so in anatomy, if you want to gain more of marks, you have to draw multiple images. Okay, so let's draw one by one. So let's draw the first one, in which we will draw a diagram that is showing you the interior. So in this diagram, we will draw interior of shoulder joint. In bracket, write down glenohumeral ligament. So obviously, whenever the interior is shown, then only we will be able to appreciate the glenohumeral ligament. Okay, so this is one diagram which you have to make. Okay, so again, here we have to draw images. So actually, we have to draw the glenoid labrum. So surrounding the glenoid fossa, deepening the glenoid fossa. And we will also draw the humerus bone. Cut part, I'm showing you the cut part for the humerus bone. Like this. Yeah. Now, okay, so this is the interior part. It is cut. It is cut so only it is like this. Okay, now. So, surrounding to this, can we use green color? Yeah. So, most outer aspect, this is the fibrous capsule. Okay. This is just a schematic diagram, but it should be anatomically correct also. Yeah. So this is the glenoid labrum. Okay. And also in the superior aspect, I would like to show you one muscle. Which muscle is this? This will be the actually we will have the long head of biceps brachii, which will be traversing through it. So we will have that. And the three parts of, now the three parts which we will make is the glenohumeral ligament. So we'll make the glenohumeral ligament here. We'll also make the glenohumeral ligament part merging here and going on this aspect. Okay, so these are all glenohumeral ligaments which I have drawn. This will be the fibrous capsule. Which will be all surrounding, merging. So you can see glenohumeral ligament is merging. When you open up the joint cavity of the shoulder joint, you can see the three bands. Okay, these three bands are of glenohumeral ligament. So basically, these are the bands of the glenohumeral ligaments. So let us label it. This is the superior. This is the superior. This is the middle, and this is the inferior glenohumeral ligament. Superior, inferior, and that of middle glenohumeral ligament. Okay, done. And this tendon which has been shown to you here will be the long head of biceps brachii. Okay. Okay, and glenoid labrum is also shown. So this is the interior which has been shown to you. And if you want to make an overall view, this will be coracoid process, ever will be going here, the acromial process like this. Okay. Done. Now I will make one more simple diagram. So we have already seen and we are understanding the points, just we are drawing the line diagram so that we can practice the line diagram, because you understand the thing, but when you go in the examination, it becomes difficult for you to draw this diagram. So once after understanding the content and theory part, you have to practice making the diagrams. Okay. So if you want to fetch good numbers, you have to draw diagrams by yourself. So now we will draw and again another line diagram showing the important ligaments of the shoulder joints. Okay. So again the glenoid cavity. This is the outline of shoulder joint which I have made. And then I will make here also acromial process. Let me use gray color for all these structures. This is the scapula. Okay, now. So this coracoid process and acromial process. So what is this? This is acromial process. This is coracoid process. And this coracoid and acromial process is connected by the coracoacromial ligament. So we will draw here green. Let me use green color. Like this. Coracoacromial ligament. Coracoacromial ligament. Okay, and this is the coracoid process. Got it? Now here I will also draw coracohumeral ligament going. So let's draw one more. So this will be the greater tubercle. So I will again use green color, and here this will again go towards the anterior. So what is coracohumeral ligament doing? It is connecting the base of coracoid process to that of anterior aspect of greater tubercle. So this is exactly. So this is exactly the ligament. And what is this? This is the greater tubercle only. So drawn. So we will, and an outline should be given for the fibrous capsule. This is the fibrous capsule which we have made. Okay, this is the fibrous capsule. So what is this? This is the joint capsule. And this ligament which we have made here is the coracohumeral ligament. Which ligament, my dear students? It is coracohumeral ligament. I would also like to draw. So we will have the lesser tubercle here. This is the greater and this is the lesser tubercle. And here the tendon, one tendon passes, that is the tendon of biceps brachii muscle. So here we can draw just an outline of the tendon passing. I can draw. And this is covered by another ligament that is called as, which is called as transverse humeral ligament. So this ligament is transverse humeral ligament. Is it okay? So we are here in this single diagram. So in the previous diagram, what I have made was was showing you the glenohumeral ligament here, and in this diagram I have shown you the coracoacromial ligament, the transverse humeral ligament, the coracohumeral ligament. So the four primary ligament along with the joint capsule and fibrous capsule has been drawn. Done. Now, next is to know the important bursas related with the shoulder joint. Till now, my dear students is having any doubt, they can ask me. Let me just check. Yeah, so let's talk about the important structures. So we have seen the important ligaments, and for the smooth movement of the shoulder joint, glenohumeral joint, we have to know about also the bursas surrounding it. So basically, there are so many bursas, but important one. So bursas related to the shoulder joint, if I talk about the important bursas which is related around the shoulder joint, we have got three. The two which is communicating with the joint cavity was subscapular, the infraspinatus bursa, and one more is subacromial bursa. So write down bursas around shoulder joint. Bursas around shoulder joint. So the bursas around shoulder joint is three important bursas. We have got subscapular bursa. We have got subacromial bursa. We have got infraspinatus bursa. Got it? So these are the three bursas around shoulder joint. Okay. Now I would like to show you the image here firstly. Okay. So we can see the subacromial bursa in this diagram. Below the acromial process, this is the acromial process. This is the coracoid process you can see. And below the coracoid process, subcoracoid bursa is also there. So this is subacromial bursa which is shown. And you can see the subacromial bursa is actually, the bursa communicates here with the subdeltoid. Some of the authors also tell subacromial and subdeltoid bursa is similar. We can also see here the coracohumeral ligament, coracoid process and that of the acromial process is connected. So actually this is very important. Together coracoacromial ligament, coracoid process and that of acromial process is called as coracoacromial arch, which is forming a secondary accessory support for the shoulder joint and preventing superior displacement or dislocation of shoulder joint. Okay, so that is a very important point. Coracohumeral ligament has been shown. So if I talk about each bursas, okay, so that is very important. Also we haven't written about the accessory ligament. I think it is already explained. So if I talk about bursa, so I just want to write few important points about the important bursas. Okay, so basically we are knowing that there are three bursas. Let's know each one of it. So I would like to first explain about subscapular bursa. Subscapular bursa, if I am talking about subscapular bursa, it is located between the tendon of subscapularis muscle and that of neck of scapula. So write down subscapular bursa. So subscapular bursa is located between tendon of subscapularis muscle and neck of scapula. And it is actually, this bursa is very important. If you remember the joint capsule and synovial cavity, which I have discussed, the subscapular bursa communicates with the joint cavity. So an important point is subscapular bursa communicate with the joint cavity. It communicates with the joint cavity. That is a very important point because this can be asked as an MCQ. Now coming to the next important bursa which I want you to explain, the second one is subacromial bursa. So let's talk about subacromial bursa. Okay. So if I talk about subacromial bursa, it is located between the coracoacromial ligament and that of, so basically it is located below the acromial process. Okay, it is located below the acromial process above and supraspinatus tendon and joint capsule on the lower aspect. So exact location of subacromial bursa will be between the acromial process and the supraspinatus muscle tendon. So it is located between coracoacromial ligament and acromial process. This lies above and infraspinatus muscle tendon, and supraspinatus muscle tendon and joint capsule lies below. So this is exactly the location of subacromial bursa. So basically it is continuing downwards beneath the deltoid. So some others also mention it as a subdeltoid bursa. Okay. So sometimes it is also mentioned as a subdeltoid bursa because it is communicating with the bursas beneath the deltoid muscle. The third bursa is infraspinatus bursa. And this infraspinatus bursa also we have studied in the joint capsule, that this communicates with the joint cavity. Okay, infraspinatus bursa will be more visible once you see the posterior aspect. So it is located between the tendon of infraspinatus muscle and the posterolateral aspect of the joint. So located between infraspinatus muscle tendon and posterolateral aspect of the joint capsule. Got it? Posterolateral aspect of the joint capsule. Got it? Okay, it also communicates. So infraspinatus bursa also communicates with joint cavity. This is also communicates with joint cavity. Done. So we have done all the ligaments. We have discussed all the ligaments. We have discussed all the bursas around the shoulder joint. We have to know about the relations of shoulder joint. What are the structures which is surrounding the shoulder joint? So that is important. And then we will talk about, after that, we will talk about the arterial supply, nerve supply of the shoulder joint. So basically that is important. And also we'll talk about the stability which is increased in the shoulder joint. So let's talk about that. That is very, very important. So either we can go with the arterial supply. So the important arteries which is giving blood supply to the shoulder joint is following. Okay, the important arteries which provide blood supply, arterial supply to the shoulder joint is mainly the following arteries. So we are knowing around the surgical neck of humerus, we have two arteries which is forming anastomotic network, and that is anterior posterior circumflex humeral artery. So anterior posterior circumflex humeral artery is a source of arterial supply. Also we have got subscapular artery and suprascapular artery. Here subscapular artery, anterior and posterior circumflex humeral arteries are the branch of third part of axillary artery, and suprascapular artery is the branch from the basically it's a branch which is coming from the superior aspect from the source of subclavian artery. So right now the arterial source is anterior and posterior circumflex humeral artery. Actually, all these arteries we have already done in the previous session. Other arteries are suprascapular artery. Other arteries are subscapular artery. Got it? So these are three sources of arteries. Now we will talk about the nerve supply. Done? Now coming to the nerve supply. So the important nerves which is giving innervation to the glenohumeral joint is axillary nerve, a very important nerve related on the inferior aspect, axillary nerve, and also we will have the innervation coming from the musculocutaneous nerve and suprascapular nerve. Got it, my dear students? So we have done well. So we have now completed all the ligaments, all the bursas, arterial supply, nerve supply, relations and factors maintaining the shoulder joint stability is important. Then we will move on to the movements. Okay. So that is important. So before that, let's draw a label diagram showing the relations of shoulder joints. Okay. So after that, we will talk about the stability and then we will talk about the movement. So for relations of shoulder joint, actually relations of shoulder joint can be through a section, sagittal section. I will make the shoulder joint. I will make a sagittal section of the shoulder joint showing the relations. So you can write on the heading relations of shoulder joint. Relations of shoulder joint. Okay, to understand the relation of shoulder joint, we are taking sagittal section. So firstly write on the heading and then we will make a diagram. Okay. Okay, so a section has been taken. So we will first draw the glenoid fossa. This shallow cavity, glenoid, G for the glenoid fossa. I'm not writing complete name because many things if I will write, then it will become slightly very much crowded. Okay, so G for the glenoid fossa. Okay, biceps tendon also I want to make attached here. Biceps tendon. Okay, we can either, yes. Now we will make bursas here, and outside that we will make the fibrous capsule. Okay, so I can either use this anteriorly subscapular bursa. Can make it slightly closer. Is it okay? Yeah. Okay, here I will just write B because B means biceps tendon. And outside this with the green color, I am going to make the fibrous capsule. Okay, we are more concerned here now about the relation. So just an outline just to make you understand that this is the shoulder joint cut section. Okay. Okay. That all I will label it. Surrounding, we have to show the muscle. So superiorly, you know, on the superior aspect, we have got supraspinatus muscle. So I am going to use brown color showing the supraspinatus muscle. So this will be the supraspinatus muscle. This is supraspinatus muscle. And as I know that, and above it, we will draw the cut part of acromial process. This is the acromial process. Okay, and in between the supraspinatus tendon and acromial process, so if you just label it here itself, so that no doubt is, this is acromial process of scapula. Okay, and this muscle which we have made is supraspinatus. Supraspinatus muscle tendon. Okay, and in between these two, I will make outline for the subacromial bursas. So sorry. This is subacromial bursa. Okay, so superior aspect structures we have made. On in the acromial process only, we have got the attachment of which muscle, bache? Deltoid muscle. So we will have here the deltoid muscle. Okay, so this is again this is the deltoid muscle. So actually I will make a section surrounding structures. I will just show. Okay, so this muscle which we have made is the deltoid muscle. Done. And actually, if I talk about the posterior aspects, actually this will be posterior relation. This will be the posterior. Okay, you can just, these are posterior relations. What is this? This is a posterior relation. So on the posterior aspect, the shoulder joint is related with the deltoid muscle. Obviously, deltoid muscle, yes. It is related with the parts of teres minor and infraspinatus muscle. So we will make these muscles. So we will make here two muscles. Again, I will use brown color for this. And actually on beneath the infraspinatus muscle, posterolateral aspect of the shoulder joint, we have got infraspinatus tendini, infraspinatus bursa. So here we can make the infraspinatus bursa also. Okay, so just label it. Okay, we can just, these are all posterior relations. So basically this muscle which I have made is the infraspinatus muscle. This is the infraspinatus muscle. This is teres minor muscle. Okay, just a minute. This is the third structure, teres minor muscle. This is infraspinatus tendon, infraspinatus bursa. Okay, got it? So we have got these structures related on the posterior aspect of the shoulder joint. Posterolateral aspect, we have got infraspinatus bursas also. Now coming to the inferior aspect. So again on the inferior aspect, we will have following structures related. So now few muscles I will made on the inferior aspect. This is one muscle which I have made, then another muscle which I have made cut section, and nerve. Yes, very nicely we already know that there is one nerve and one artery. So we will have posterior circumflex humeral vessel, and we will have the nerve. Okay, and the muscles. Okay, the muscles. So just use brown color for the muscles. Okay, draw the diagram along with me, and which structures are related on the inferior aspect. So the structures related on the inferior aspect, just highlighted, and we have got the structures. What are they? They are the muscles which I will make. The muscles, axillary nerve, posterior circumflex humeral. So we have got posterior circumflex humeral vessels, axillary nerve. We have got the triceps muscle, long head, and so here this is the please label it. This is the long head of triceps. This is long head of triceps. Okay, we have got long head of triceps. We have got posterior circumflex humeral vessels and axillary nerve. Okay, so this is, and this, is it okay? Yeah. So this is axillary nerve. This is posterior circumflex humeral artery. So 1, 2, and 3. So these three structures are again inferior relations. These are inferior. These three structures together are inferior relations of shoulder joint. Okay, inferior relations. Got it? So till now, superior aspect, we have got supraspinatus muscle on the superior aspect. And also subacromial bursas on the superior aspect. And we have got coracoacromial arch and ligament. These are all the structures on the superior, and part of it is also anteriorly. So we will draw that. Now coming to the other structure. So we will have here surrounding structure. This is teres major muscle part. Okay. Now coming to again, now coming to the anterior relation. So here again, I will also make here coracoid process. Okay, the coracoid process is connected via coracoacromial ligament. And also it is attached to the muscles tendon, these two muscles tendon. Okay. Got it? And overlapped by the fibers of deltoid muscles. Also we have got deltoid muscle, which will be covering all these structures together. Okay. This is the deltoid muscle. This is subacromial bursa, which name of acromial name you can just write above. Got it? Yeah. So this is the outline for deltoid muscle. This is also deltoid muscle. Okay. And this is the tendons which is at. So here we will have. So actually this structure which you are seeing is the coracoacromial ligament. So actually these structures, supraspinatus, subacromial bursa, coracoacromial ligament, these are together. We can say these are the superior relations. These are superior relations around the shoulder joint. This is superior relation. You can say these all structures are in the superior aspect. Okay. And we will have actually, other than that, we will have the part of deltoid, which is also, this is the deltoid muscle. And few structures more anteriorly, that is, we will have coracobrachialis muscle and the biceps muscle. So here these muscles which you are seeing, please write down, this is coracobrachialis and short head of biceps brachii. And short head of biceps brachii. Okay. And this is obviously deltoid muscle which we have written. Okay. 1, 2, 3. Okay. What all structures anteriorly? So anteriorly we will have the subscapularis muscle also. So here we will draw the subscapularis muscle around it. And we will have more anterior to it, we will have the pectoralis major muscle. And here we will have the cut part of axillary vein and axillary artery. This is axillary artery and this is the axillary vein. And these muscles are the anterior relation subscapularis. And subscapularis bursa also. So let's write it. This is subscapularis bursa. This is subscapularis muscle. This is axillary nerve and vein. Sorry, axillary artery and vein. And on anterior aspect we will have so actually pectoralis major muscle. So basically they are around surrounding structures. So major structures which will be lying in the anterior relation will be coracobrachialis. We will have coracobrachialis muscle overlapped by the other muscles will be there, that is deltoid and all. So these structures, short head of biceps brachii, these structures basically coracobrachialis, subscapularis muscle, the subscapularis bursas, the subscapularis muscle, and the short head of biceps brachii, which you are seeing, all these structures are forming the anterior relation. Anterior relation. So basically in this diagram, we are aware of superior, anterior, posterior relations and inferior relations. Okay, so you can just highlight this. So we are seeing here posterior relations, we can appreciate superior, we can appreciate anterior, and we can appreciate inferior relation. So this is exactly the cut section of the diagram which is drawn to show you the surrounding structures and relations of shoulder joint. Okay, so done. So done. And obviously what does G stands for? G stands for glenoid fossa. If you want the full form, then you can write if you are confused. But I think so many G for the glenoid fossa, my dear students. What does B stands for? Long head of biceps brachii. Okay, so done. So don't worry, now we have not to draw any diagram. We have finished the diagram making part. I know many of the students get so much pain, ma'am, so many diagrams, how we are able to make. So just these are diagrams you have to make. One diagram showing the relation of shoulder joint, few diagrams showing the ligaments and interior of the shoulder joint so that you can appreciate the glenohumeral ligament and the surrounding ligaments. Done. So now after this, I would like to tell that what are the 4 points which increases, what are the 4 factors which increases the stability of shoulder joint. So till now it is quite aware to us that the glenoid fossa is shallow in comparison to the head of humerus, but it has many of the cases of recurrent dislocation is reported, but then also it is stable joint. So how the stability is increased? The stability is increased by following factors. So write on the heading factors providing stability to shoulder joint. Factors providing stability to shoulder joint. So the factors which provide stability to the shoulder joint is following. So we have got 4 factors which is important for increasing the stability of shoulder joint. So few of it we have already discussed. If you know rotator cuff muscles, in the previous session we have discussed rotator cuff muscle, which is composed of 4 muscles, SITS, S-I-T-S, supraspinatus, infraspinatus, teres minor and subscapularis. So rotator cuff muscle, which is actually a musculotendinous cuff, which is formed by 4 muscles, which is actually the tone of rotator cuff muscle is grasping the head of humerus towards the glenoid fossa, increasing the stability. Rotator cuff muscle, which is forming musculotendinous cuff, increasing the stability of shoulder joint. What is it? It is SITS. And we already know what is SITS. Supraspinatus, infraspinatus, teres minor and subscapularis muscle. We have done in the previous session. Other is coracoacromial arch. So when I am using the word, so exactly, if I am talking about SITS, if you want to know what is SITS, S-I-T-S, it is for which muscle? Supraspinatus muscle, infraspinatus muscle, teres minor, subscapularis muscle. Okay, these are the 4 muscles which forms the whole component of SITS. Okay, done. Okay, now other than that, okay, so other than that, okay, other than that, we have got coracoacromial arch, which is formed by 3 structures. coracoid process, acromial process, coracoacromial ligament. This is preventing the superior dislocation of shoulder joint. This is supporting the shoulder joint superiorly. We have got glenoid labrum, which is very important structures. So this glenoid labrum is very important. Why? Because it is deepening the glenoid fossa cavity. And the other one is the long head of biceps tendon. So basically we have discussed all of it and we are knowing the details. So we have discussed all of it and we are knowing the details. And it is very important that you should understand all the factors which increases the stability of shoulder joint. Okay, this will be asked also in the examination. Now coming to shoulder joint. So now coming to the movement. So we know that shoulder joint is a highly mobile joint. So the freedom of mobility is present because of the lax joint capsule. Articulation is between the head of humerus large in comparison to the glenoid fossa, which is shallow. So to permit the movement, so the glenohumeral ligament is permitting the movement in following group: flexion, extension, abduction, adduction, medial and lateral rotation, and also circumduction. These are the movements which is possible. Now I want everybody to see this image so that you can understand the movements which is possible in the shoulder joint. So as you can see, the first image is showing you the flexion extension movement. So when I talk about flexion extension movement, it is occurring in the sagittal plane along the frontal, that is coronal axis. So this is flexion and this is extension. Okay, this is flexion and this is extension. Okay, for that I have to stand. So I have very nicely you can appreciate in this diagram. One of the important crux point is that flexion extension is happening in sagittal plane along coronal axis. Now what about the abduction? So we have seen the first category of movement, flexion extension. Now coming to the second category, adduction abduction, that is occurring along the frontal plane, that is coronal plane, around which axis? Sagittal axis. Okay, now medial and lateral rotation. So this is medial rotation and this is lateral rotation. So medial and lateral rotation occurs in transverse plane around vertical axis, and the combination of this all movement is the circumduction movement. Okay, so the circumduction movement is the combination of all these movements, which is important for you to understand. So if I talk about circumduction movement, it is the movement which is taking place in glenohumeral joint in a orderly manner. That is firstly what happens, we have got flexion, then we have got abduction, then extension, and then adduction. So this is called as circumduction movement. Okay, so that sequence is important. So I just want that you should be knowing about these movements and occurring in which plane. So please write down this. So all of you please write down just one line about each movement, because movement of joint has been asked so many times in the examination. So the first movement will be flexion extension, flexion and extension movement. The second is abduction adduction movement. The third is medial lateral rotation, and the fourth is the combination movement, that is circumduction movement. Okay, that is the combination of movement that is called as circumduction movement. So just understand that this movement is happening in which plane and around which axis, which is important for you to know, because this is asked again in the viva examination. So I will show you one more image for that movements. So let's if I talk about flexion extension, it is actually occurs in sagittal plane. It occurs in sagittal plane around coronal axis, which is also called as frontal axis. Okay, if I talk about abduction adduction movement, it occurs in coronal plane around sagittal axis. around sagittal axis. Now medial and lateral rotation. So if I talk about medial and lateral rotation, it occurs in transverse plane around vertical axis. And the combination of this movement is circumduction. And I just want you to note down, actually I think this I have also done in the class of joints, but circumduction is a combination movement which is happening in the glenohumeral joint, and the orderly sequences, so orderly sequence of this movement. The orderly sequence of movement is as following. What is it? So we will have, firstly we will have flexion, followed by abduction, followed by extension, and then adduction. Okay, and just the reverse of it. So that is the combination movement, that is circumduction movement. Okay, so done with this. Now it is also important, actually I will explain a mechanism of abduction separately, because this is also asked as a short note or a viva question. But before that, it is important to know which all group of muscle is performing this movements on around the shoulder joint. So done with this. Now, before proceeding, I just want everybody to understand what is the plane of glenohumeral joint movement. So basically the plane of glenohumeral joint, so basically if I talk about the scapula, it does not lie exactly in the coronal plane, but it is oriented. Glenoid cavity is directed forward and lateral. It is facing more forward and laterally. Therefore, the plane of glenohumeral joint is slightly oblique, approximately 45 degree to the sagittal plane. So we have to understand that all movement is happening around this plane. So now let's see this. So already I have told you basic movements are flexion, extension, abduction, adduction, medial and lateral rotation. So it's important to know which muscle is causing this group of action. So let's talk about that. So firstly, I will talk about flexion movement. Okay, so flexion of shoulder joint is done by following muscles. The first movement, it is done by pectoralis major muscle, and I have already told you pectoralis major muscle, clavicular part. So prime muscle is the pectoralis major muscle, clavicular part. And also the flexion of shoulder joint or arm is done by deltoid muscle, anterior fibers. Anterior fibers means clavicular part. These are prime muscles. Accessory muscles can be the biceps brachii, short head. Accessory muscles can be biceps brachii, short head, coracobrachialis. Now coming to extension. The second movement is extension movement. So if I talk about extension movement, it is primarily done by the deltoid muscle posterior fibers. Whenever I am using the word posterior fibers, it means the spinous part of deltoid muscle. We have already talked this in the previous session also. And one more muscle is latissimus dorsi muscle, which is the bulky muscle in the back. Okay. Accessory muscles will be triceps, long head, teres major muscle. Such kind of muscles are accessory muscle. Teres major muscle, these are accessory muscle causing extension. Now we will talk about adduction and abduction. So let's talk about third movement, adduction. Adduction of arm or shoulder is done by pectoralis major sternocostal fibers and latissimus dorsi. They are prime adductors of shoulder joint. Pectoralis major sternocostal fibers and latissimus dorsi muscle. Okay. Other accessory muscles are coracobrachialis muscle. Abduction. Actually, this is a prime movement, and so many times MCQ is asked from the topic of abduction of shoulder joint, which muscles are causing this action. So basically there are multiple muscles which is performing abduction. So this is done by supraspinatus. This muscle is causing initiation of abduction, that is 0 to 15 degree approximately. And acromial fibers of deltoid muscle, this is the prime abductor which is causing 15 to 90 degrees of abduction. And overhead abduction, is done by, basically if I talk about overhead abduction, it is done by the serratus anterior and trapezius muscle. Acting together, that is greater than 90 degree abduction. So serratus anterior muscle acting with the lower fibers of the trapezius muscle. Now we have done, now we have to also know the muscle causing medial and lateral rotation. So medial and lateral rotation. So write down muscle causing medial and lateral rotation. Medial rotation is done by subscapularis muscle, also by the pectoralis major muscle. Medial rotation is also done by teres major muscle. Lateral rotation is primarily done by infraspinatus and that of teres minor muscle. So lateral rotation. So actually, if I talk about deltoid anterior fibers, they cause medial rotation. So you can also write deltoid muscle anterior fibers will cause medial rotation, but deltoid muscle posterior fibers will cause, or spinous fibers will cause lateral rotation. Okay. Now other muscle, infraspinatus and teres minor muscle. Okay. So these actions is very important for you to understand. This is asked in examination. Okay. Now we have done with this. Now let's talk about the movement abduction of shoulder joint. I want you to know. So then I will come to clinical anatomy. So please write down one of the important point, that is mechanism of abduction. Okay, mechanism of abduction. So actually abduction is a complex movement which is happening at the glenohumeral joint, and total range of abduction is large. It is 180. So the abduction range which can be performed at glenohumeral joint is 180 degree of abduction. So basically, according to the older concept, it is like the total range up to 90 degree of the abduction occurs at glenohumeral joint, and beyond that, if I am talking about, this is for that moment the humerus has to move laterally. So we can categorize till 90 degree, till 120 degree, and above 120 degree. So till 90 degree at glenohumeral joint, above that till above 90 to 120 degree, the humerus has to move laterally, and after that 120 to 180 degree, the scapula has to rotate forward towards the chest wall so that the abduction movement is completed. So the detailed analysis I will give you, don't worry. So total range is 180 degree. So let's first is, this is actually older concept, but if I go to the newer concept, that according to the older concept, abduction of the shoulder at 90 degree is performed at glenohumeral joint, and beyond that the scapula has to move and rotate so that the upward, so that the rotation is, abduction is completed. But recently it has been established that that through the fluoroscopic study, it has been established that rotation of scapula start even before, in the initial stage of abduction also. Okay, so that is an important point. So the articular surface of head of humerus permit the elevation of arm only up to 90 degree. Up to 90 degree. So because greater than 90 degree, actually what happens till this, so up to 90 degree, and after that, if it is greater than 90 degree, then it will, greater tubercle will impinge under the acromial process. Okay, so permit elevation, so that means till 90 degree, movement is happening at the glenohumeral joint. Okay, glenohumeral joint, because articular surface of head of humerus can be easily elevated up to 90 degree. After that, beyond that, greater tubercle get impinged under the surface of acromial process. Beyond 90 degree, the greater tubercle impinges upon under surface of acromial process. So further movement to happen, so for that further movement to happen, lateral rotation of arm occurs. So this can be released. So for releasing this further movement, so for releasing that, so for this second, so that means in the second section, so basically further movement, for further movement, lateral rotation of arm occurs. Got it? Okay. So that means arm rotates laterally. So that means our arm is rotating laterally, so that 90 degree to 120 degree of abduction is possible. But beyond this 120 degree. But the third case is abduction above 120 degree can only be possible if the scapula rotates. So the scapula has to move forward towards the chest wall, so that greater than 90 degree, greater than 120 degree of abduction is possible. So greater than 120 degree abduction can occur only if scapula rotates. Okay, that is important. So scapula rotates forward. So for this, scapula will, for this to happen, scapula rotates forwards on chest wall. Okay, this is very important for you to know. So you can just, that means till 90 degree, the whole part of glenohumeral joint is filled, and impingement of the, if I talk about the impingement of greater tubercle is happening beyond 90 degree. After that, lateral rotation of arm takes place, and after lateral rotation, further greater than 120 degree of abduction to be possible, the scapula is rotating forward, so that this whole 180 degree of abduction is possible. So basically the rhythm has to maintain. So basically there is a rhythm. So only we tell that it's a joint, shoulder joint is a complex. Not only the movement happens in glenohumeral joint, but other joints are also involved. So that rhythm of movement is happening between scapula and the humerus movement, and this is called a scapulohumeral rhythm. So that means for 1 degree of lateral rotation of scapula happens for every 2 degree of movement of scapulohumeral joint. So that is very important. So in short, in simple terms, you can write the humerus and scapula move in the ratio of 2 to 1. During abduction movement. Okay, so that means for every 15 degree elevation, the humerus move 10 degree and scapula moves 5 degree. Okay, that is important. So that means during the early and terminal stage of elevation, the sternoclavicular and acromioclavicular joint moves maximum respectively. So this is another note point. So only it is called as joint complex, shoulder joint complex, because sternoclavicular, acromioclavicular and the scapulothoracic linkage functionally also is involved. So basically that means during early and terminal stage of elevation, the sternoclavicular and acromioclavicular moves maximum respectively. So only we study this together as the shoulder joint complex. Okay. So with this, we have done all the gross part. We have finished the gross aspect of movements, the ligaments, the stability, the bursas. Now I would like to tell few points about the clinical anatomy, and then we will solve few MCQs and we will finish the important topic of shoulder joint. So let's do that. So Frogen's shoulder, one of the clinical cases, adhesive capsulitis, which is called as Frogen's shoulder. So this is a clinical condition where the movement of the shoulder joint is limited. It is the patient is generally greater than 45 degree, greater than the age of 40 degrees, 40 years or 45 years, and the basically there is not much of radiological changes, but actually what will be seen is there is uniform limitation to the movement. So thickening of the joint capsule is there, and the condition is generally seen by 40 to 60 years of age. And there is capsulitis. So the frozen shoulder limitation and painful movement is there for all the movements of shoulder joint, and this is due to adhesive or means more of adherence to fibrous capsule. This is the reason. Now coming to the another point, dislocation of shoulder joint. So basically dislocation of shoulder joint, if I talk, it is more happening in the inferior aspect. Why it is inferiorly least supported? You know, the fibrous capsule attachment extend towards the surgical neck. Fibrous capsule is attached to to the anatomical neck, but in the inferior aspect it descends 1.5 centimeter down towards the surgical neck. So that means clinically, if I talk about the description of anterior and posterior dislocation, is in term whether the humerus head is descending anterior or posterior to the infraglenoid tubercle. So this is supraglenoid tubercle and this is infraglenoid tubercle. So considering the point of infraglenoid tubercle, we describe it as an anterior or posterior dislocation. Inferiorly, the shoulder joint is least supported. Okay. So shoulder joint dislocation occurs inferiorly. So why inferiorly? Because it is inferiorly least supported, which we are knowing, because that is the due to the attachment of joint capsule. But in clinical condition, if I talk about anterior and posterior dislocation, if I am talking about anterior or posterior dislocation, the description is taking the anatomical landmark. So this will be judged indicating whether the head of humerus descends anterior or posterior to the infraglenoid tubercle of scapula. This is very important point, infraglenoid tubercle of scapula. So basically, and dislocation is more seen when there is excessive lateral rotation, and actually a prominence of shoulder point will be seen, and the stability of shoulder joint is hampered, and also axillary nerve will be involved. When it displaces inferiorly, the axillary nerve is involved, and it will lead to the paralysis of deltoid muscle. So done. Now painful arch syndrome, which is also called as supraspinatus syndrome. So basically it is related to the surrounding pathologies like supraspinatus tendinitis, there is subacromial impingement, and also typically the pain is between, if I talk about the pain, it is more between it is seen between 60 to 120 degree of abduction. It occurs when the rotator cuff muscle, mainly the supraspinatus muscle, is getting compressed, and it is actually compression of supraspinatus muscle tendon can be seen below acromial process. There can be other reasons like supraspinatus tendinitis, calcification of deposit in the tendon of supraspinatus muscle, subacromial bursitis, and also injury to the greater tubercle of humerus. So these are painful arc or supraspinatus syndrome causes which has been mentioned here. Minor tear of the muscle. Then there is also supraspinatus tendinitis. Beneath the acromial process, calcific deposit, subacromial bursitis, inflammation of subacromial bursa, injury to the greater tubercle of the humerus bone. Okay. Now, I just want you to tell that if you will see this pain of the acromial bursitis or supraspinatus tendinitis, the pain is due to mainly the pain will be due to the inflammation of subacromial bursa. So it is elicited when deltoid is pressed just below the acromial process, when the arm is adducted. So this is the process to establish the clinical condition, and in this case when the compression is done below the acromial process and when the arm is adducted, as you see in the image, this is the A image and this is the B image. Now the pain cannot be elicited at the same point when the arm is abducted. In the second image, you can see the arm is abducted because the bursa disappears or slips under the acromial process, and this sign is called as, it is very important for you to note down what is this sign called as. This is called as Dobran signs. Okay, so when at the same point when the compression is done, that is just below the acromial process, but the arm is in another position, it is in more of abducted position, the bursa slips or disappears under the acromial process and the pain is not felt. So this is called as Dobran signs, which is very important for you to understand, and it is well appreciated in image A and B. Image A is the condition where we can feel the pain because of subacromial bursitis. Image B is releasing the pain. Another clinical condition is osteoarthritis. So osteoarthritic condition of the shoulder joint is less common as compared to hip joint and knee joint. So in this case, you can see this is the joint capsule which has been, this is a joint cavity which has been severely reduced, and there is limitation to the movements. Okay, osteophytes are also formed. So, and if we talk about the osteoarthritic condition, that is wear and tear and disuse of the cartilage. So there is wearing and tearing of the cartilage of shoulder joint. This is more commonly seen in the lower limb joint, but it can also happen in the shoulder joint condition. So let's solve few of the MCQs related to the topic. So let's start with question number 1. So let me just ask the students if everything is fine, they are understanding. Any doubt, then you can ask me. Okay, one of the following muscle is not a medial rotator of shoulder joint. So I have already talked about all the muscles causing action around the shoulder joint. So which is not causing medial rotation of shoulder joint? Which of the following is not a medial rotator? Okay, pectoralis major, teres minor, latissimus dorsi. So actually, if we talk about teres minor, this muscle is lateral rotator of shoulder joint. This causes lateral rotation of shoulder joint, not medial rotation. So that is the right answer. Coming to the next question, all of the following muscle causes retraction of scapula except. So trapezius, rhomboides major, minor, levator scapulae. So this also in the previous session also we have done. We have got levator scapulae muscle which is not related to the function of retraction of shoulder joint. It elevates the shoulder scapula. Question number 3. After surgery done on the right side of the neck, a person could not raise his arm above the head and also not shrug the shoulder. So no overhead abduction, no shrugging of shoulder. So which is the possible cause? Damage to spinal accessory nerve, damage to axillary nerve, paralysis of latissimus dorsi, paralysis of deltoid. So basically deltoid, axillary nerve is supplying the deltoid muscle, and deltoid muscle has got a prime action of abduction, but raising, if I talk about overhead abduction, that is done by the serratus anterior muscle along with trapezius muscle. And what is the nerve supply of trapezius muscle? Spinal accessory nerve. So trapezius muscle is an important muscle which is causing the action of shrugging of shoulder and overhead abduction. Paralysis of latissimus dorsi is also not the right answer, because latissimus dorsi has got a prime action of adduction and extension of arm. Muscle of arm with an additional supinator action. Biceps is the muscle which is also having the supinator action. Okay. So this tomorrow also the classes of arm. So we will discuss this in detail. Now, if I talk about biceps brachii muscle, it has got an additional action of supinator action, and it is actually a prime role as flexor of elbow, but it is also supinator of forearm. So this is important for you to understand. What about other? So yes, brachialis is a prime flexor. We know biceps is the flexor and supinator both. Coracobrachialis is adductor of shoulder joint, and triceps is extensor of elbow joint. Intracapsular but extra synovial structure. So we have got 4 options. Which of the following is so many times I have made the image, and I think till now you must be knowing that which is the intracapsular tendon, that is the long head of biceps brachii. So obviously the right answer is B. Okay, so long head of biceps brachii is covered by a synovial pouch, and it passes in the bicipital groove. So this is and it lies inside the joint cavity. So we have done with the today's session. We have studied shoulder joint, glenohumeral joint in much more detail. So all the 5 questions and all the theory questions, all the diagrams we have made together. Okay, so so what are the important things you have to know? All the ligaments, all the movements, all the muscle performing the movements, abduction movement, clinical anatomy, and the relations of shoulder joint. So we'll meet again tomorrow 6 p.m. with a topic of arm. So be prepared and just revise shoulder joint. If any of the students have not understood shoulder joint, any doubt, do ask me live in the session. All the best and keep studying. Thank you so much.